Good day. I'm Mark Pegram. I'm a medical oncologist in the Division of Medical Oncology at the Stanford University School of Medicine. I do breast cancer research at Stanford. I'm involved in laboratory research with a focus on therapeutic strategies targeting HER2. And I also conduct clinical trials, particularly early phase clinical trials, but ranging all the way into pivotal phase 3 registrational trials as well. It's a difficult question to know exactly how to counsel patients with a new diagnosis of breast cancer. This challenge is made even more complex by the fact that breast cancer, of course, is not just one disease. And so the first thing I tell patients is if they're comparing notes with friends of theirs in the waiting rooms or in the infusion centers or friends and neighbors who may have a history of breast cancer, is that breast cancer is different in every single patient. These tumors are literally like snowflakes. No two are alike. And consequently, even though two patients may have the same size tumors, the same number of lymph nodes, maybe the same steroid receptor status and nearly the same age, their treatments may be very different indeed. And so that's the first and most important lesson, is that these are patient individualized treatment recommendations for breast cancer in the modern age. And it's difficult to compare notes with friends, neighbors, or colleagues in the waiting room. The second thing I try to tell patients up front, especially those with stage 1 or stage 3 disease, earlier stage, is that breast cancer is curable for most patients with stage 1 or 2 disease and many patients with stage 3 disease. Even some stage 4 breast cancers can be apparently cured. For example, the HER2 positive exceptional responders who have clinical complete responses with metastatic disease, their event rate in terms of progression events is very low indeed, if any. And also those HER2 positive patients who present with oligometastatic disease may also be treated with curative intent indeed. I also advise patients there are no bad questions for the oncologists. Many times the simplest questions are indeed the most difficult. And in some cases, we don't even have the answers to even simple questions. For example, why did I get breast cancer? That's probably the most frequently asked question in breast medical oncology, and probably the question that we don't have the answer for the most frequently. I try to discuss logistical concerns that these patients are going to be seen by surgical oncologists, medical oncologists, radiation oncologists, imaging experts, echocardiography technicians. They might have to go to nuclear medicine. They may need a port placement if they are destined to receive neoadjuvant or adjuvant chemotherapy or antibody therapeutics. They may need a DEXA scan if they haven't had one as part of their routine health maintenance, if they're going to be considered for aromatase inhibition. So this is going to be a long logistical journey with a diagnosis of breast cancer. There are many appointments, many visits to many different laboratories and imaging clinics to get all the data we need to make informed decisions. I try to discuss the pros and cons of various imaging modalities, including mammography, sonography, MRI. I discuss pathology reports in detail with patients, including the importance of the biomarker phenotypes and how that may impact on treatment decisions. I discuss local control measures for early stage breast cancer, including surgical options. I talk about the principles of radiation therapy and common side effects of radiation therapy. I discuss that there may be novel approaches that are investigational for both surgery or radiation therapy. I talk about the risk of relapse. I discuss the concept of proportional reduction in relapse versus relative risk of recurrence. It's very important to know that some doctors may say, well, you have a 33% reduction in relative risk of relapse, but it's 33% of what? If your risk was only 10% to begin with, 33% of 10% is only 6 or 7%. So it's the absolute risk that patients mostly are impressed by, not proportional or relative risk reductions. I discuss that treatments have evolved in many cases due to the advent of sophisticated diagnostic approaches, such as the Oncotype DX assay, that can determine which patients are most likely to benefit from systemic adjuvant chemotherapy versus those who simply don't need it, allowing for consideration of de-escalation of therapy, elimination of chemo indeed. Another example of de-escalation in HER2-positive early breast cancer is for patients with small tumors, perhaps less than about 2 centimeters and clinically node negative. They may safely forego combination chemotherapy regimens with dual anti-HER2 antibody therapy and instead merely take weekly low-dose paclitaxel plus trastuzumab for 1 year. There's clear evidence also to support dropping anthracyclines in HER2-positive early breast cancer, dropping anthracyclines altogether. Even in higher risk subset analysis in the BCRG-006 trial and in the TRAIN-2 study showed no benefit from the addition of anthracyclines in any subset for HER2-positive early breast cancer. I talk about genetic risk more and more often, especially in the wake of the Olympia trial, including consideration of adjuvant olaparib, which had a big treatment effect. Since BRCA mutations are now actionable in the adjuvant setting for high-risk early-stage newly diagnosed breast cancer, and because we have this new therapeutic olaparib for consideration in the adjuvant setting, and because of its clinically meaningful and impactful results with predictable toxicities, I think it behooves us to talk about genetic testing for the lion's share of patients who might be eligible to consider PARP inhibition in the adjuvant setting. I talk a lot about expected toxicities from all the potential treatments, so patients feel well informed, and that empowers them to participate in clinical decision-making and hopefully improves their compliance if they don't have any unexpected surprises or side effects. Hopefully, with a thorough discussion in advance of what the expectations actually are, patients will be on the lookout for potential toxicities that are common and not be surprised or scared by them. Next is communication. At my institution, we have electronic means through the medical record system to reach out back and forth between doctors and patients. We use email frequently with encrypted email content. We have a 24-hour after hours and weekends holidays hotline for oncology patients at my institution. We have telehealth available for patients who live a long distance. So frequent communication promotes early intervention in case of side effects so that we can improve results using dose modification or co-modification to control side effects. And this also should improve patient compliance with important treatments. And finally, I always like to spend time talking to my patients about clinical trials. Clinical trials in breast cancer research are often the most state-of-the-art treatment paradigms available in 2021. Even if patients are randomized in a phase 3 pivotal trial, if they're randomized to the control arm, they are still assured to get the very best available treatment possible with particularly close follow-up as mandated in the protocol document, which is enforced by the FDA. So it's very important to discuss clinical trial eligibility with all of our newly diagnosed breast cancer patients. They more and more frequently in the modern era are eligible for one or more clinical trials, and that advances the field forward even that much more quickly so that new and important therapeutics can make it to our patients as swiftly as possible. Thank you very much for your attention on this summary of what I think about when I'm first talking to a newly diagnosed patient with breast cancer in 2021.